costing over $20 billion annually in the United States. So where do we get our guidelines from? It's from the Surviving Sepsis campaign. And like anything great in the United States, we have corporate greed to thank for our sepsis guidelines. In 1997, the Bayer Corporation launched an international sepsis forum uh, in anticipation of one of their positive drug trials because they wanted to kind of push this drug to market for it to be used in sepsis. And it was a monoclonal antibody against tumor necrosis factor. This trial was not successful and they abandoned it. But the original grant of the sepsis forum was left intact. And what the doctors on this forum wanted to do was improve our understanding and management of sepsis. So they collaborated with the Societies of Critical Care Medicine and European Societies of Intensive Care Medicine to launch the Surviving Sepsis campaign, who have updated the guidelines approximately every 4 years, and the last of which was in 2021. So we're kind of due for a new update. But the Surviving Sepsis campaign was launched at a time that was very important in critical care management. At the turn of the millennia, there was a lot that was changing. There was like it always is, medicine is an evolving field, but this was at a time when our management of ARDS with protective lung ventilation was widely being implemented. Our glycemic control targeting a glucose of less than 180, and hemoglobin thresholds were decreasing from 10 to 7 based on a late Canadian paper that came out in the late 1990s. So, it was only natural that we improve our management of sepsis following these other changes that were happening. I used to have the logos on this slide. The Surviving Sepsis campaign was not without controversy. It was initially funded entirely by the Lilly, Baxter, and Edwards Laboratories corporations, which had conflicts of interest, and in that they wanted to push their drugs and devices to market. So as a result, the Surviving Sepsis campaign cut ties with these corporations and fully disclose where their funding comes from now. So it is a much more unbiased way of telling us what to do as providers based on the latest research. But where do we get our definition of sepsis from? In SIRS criteria, this may seem familiar to many of you. We ultimately have Dr. Bone, who's considered to be one of the founding fathers of critical care medicine, to thank for our initial definition of sepsis. And what he proposed was that sepsis was a spectrum of disease which can range from a less severe inflammation to a more severe form with evidence of hypoperfusion, and then this can lead to septic shock, which is a life-threatening, circulatory failure requiring vasopressors. And so, I won't kind of get into what SIRS criteria is having a fever or hypothermia, it's heart rate that's high, somebody's breathing fast, or, they have a leukocytosis or leukopenia. But what's the problem with SIRS criteria? Why was this being relooked at, and why do we want to change the screening tool that we have? It's because it's not great, but it's far from ideal in identifying patients that have true infection. It's a sensitive, meaning it has a fairly high sensitivity but low specificity, which means we're going to have a lot more false positives in patients that are presenting to the emergency room, which is not helpful because anyone with a panic attack will have 2 or more SIRS criteria, and we're kind of left scratching our heads. What do we do with this information? Do they have an infection or not? And this is where our clinical kind of suspicion is at play. So in response, the Surviving Sepsis campaign in 2016 sought to change our definition of sepsis. And they changed it, which is still the definition today. They changed it to what is now a life-threatening organ dysfunction caused by the dysregulated host response to infection. And this was done the way they kind of went about doing this was in a retrospective cohort study that they published in trying to implement their sepsis 3 definition. And what they proposed was, instead of using SIRS criteria, we now use a SOFA scoring system, or quick SOFA scoring system, to identify patients with dysregulated inflammatory response to infection. And the problem with this is what they're suggesting is that we have some component of multi-organ failure in order to diagnose sepsis. They eliminated the severe sepsis category altogether, and then septic shock was refined to be fluid unresponsive hypotension with a lactate that's elevated, and then a vasorepressor requirement to maintain a MAP of over 65. And so for those of you who don't remember all the components to the SOFA scoring system, this is what they are. What's interesting, though, is when you read all of the 93 recommendations of the Surviving Sepsis campaign is you won't find SOFA or QSOFA recommended as a tool to be used in identifying patients with sepsis, despite launching this big or conducting this big retrospective cohort study. And in part, the reason is because of what the Infectious Disease Society of America's response was, which is, they weren't necessarily too happy with the way this study was conducted because the patients didn't necessarily have true infection, or that couldn't be proven. But more importantly, it doesn't consider patients that don't have multi-organ failure, that have bacteremia, which is a life-threatening illness that needs to be treated. And so, where are we now? And I included this metaphor or this analogy to sepsis, which is Lost, because it's a show that's gotten me through my midlife crisis as a single hospitalist living in Grand Junction. But on this show, you're kind of confused all the time, and you're not necessarily from what era the guidelines are coming from, or what a weak versus a strong recommendation mean based on a low or a high quality of evidence. We're kind of left scratching our heads. And so where are we now? Well, the definition is still a life-threatening organ dysfunction caused by a dysregulated response to infection. And yet we've reverted back to Dr. Bone's method of identifying sepsis by using the SIRS criteria screening tool, which is having 2 or more SIRS criteria with clinical evidence of infection. And we can also use one of these other NEWS or MUSE criteria, which are strikingly similar to SIRS criteria. We don't have a severe sepsis category now, and our septic shock is now defined based on the 2016 definition, which is lactates high, fluid unresponsive hypotension, and mean arterial pressure of, needing a vasopressor requirement to maintain our MAP of 65 or greater. And, there are a lot of recommendations. I mean, the Surviving Sepsis campaign has more guidelines than a protractor, but, what they've done is they've attempted to make these bundles in order to organize what the most important components of our management are. And we initially started with 6 and 24-hour bundles, then we went to a 3 and 6-hour bundle in 2016. Now we're at a 1-hour bundle, and then this changed in 2021 to a 1 and a 3-hour bundle. So if you're not confused yet, I'm not going to change that. But what the bundle means, what's in the bundle. So what I mean when I say bundle is that these are things that should be happening ideally within the first hour, meaning getting a lactic acid and repeating it if it's high, getting blood cultures before antibiotics, administering 30 milliliters per kilogram of IV fluid if there's hypoperfusion, and starting vasopressors to maintain our mean arterial pressure of over 65. So we'll start at now. We're going to get into kind of analyzing why these things are included in the bundles. And before we do that, the reason why we want to get blood cultures before antibiotics is so that we can hopefully tailor our antibiotics based on our culture data. But what will happen if we don't? And this comes from the FABLE trial, which was a prospective cohort study done in 2013 to 2018. And what it did was it separated patients into 2 groups. Those, all the patients had septic shock, and the patients, half the patients got blood cultures before antibiotics, the other half didn't. And what they found was that there was a difference of 12% in blood culture positivity. I mean, the patients that got blood cultures after antibiotics got them within the first hour, or an hour after antibiotics were given. So why am I bringing this up? Because if there's nothing else you take away from today's presentation, it's that giving antibiotics are the most important aspect in treating sepsis. It's what improves mortality outcomes the most. And if for some reason there's going to be a significant delay in getting blood cultures, we should really be giving antibiotics first, regardless. especially if our patient is in septic shock or having or very sick, having perfusion abnormalities or end organ damage. So why am I harping on antibiotics? What do the guidelines suggest? They suggest, if somebody has shock and we're not sure if there's true infection, we should be giving broad spectrum antibiotics within the first hour. The way the guidelines have changed, and we now have this 3-hour, 1 and 3 hour bundle, is for those patients who are presenting with 2 or more SIRS criteria, and we're not necessarily sure if infection is contributing to their inflammation. And now they suggest that we have 3 hours to decide whether or not to give antibiotics. So problem solved, right? And not necessarily. And I think it's important to note that a lot of emergency room providers will order procalcitonin. I personally, like that they order procalcitonin sometimes because I think it can be useful, despite the fact that the guidelines suggest not using it. And what procalcitonin is an acute phase reactant that is particularly elevated in bacterial infections, mostly, especially gram-negative bacterial infections. But it can also be elevated after surgery, major trauma, et cetera. And it's normally involved in our calcium metabolism. So I wish we could use it. I wish the guidelines suggested using it. It just hasn't been studied in this way. It's mostly been looked at in de-escalating antibiotics in the ICU. So what will happen if we wait to give antibiotics? And if you remember, I stated that the mortality of sepsis has increased or has improved over the last several decades. And this study is a great study that looks at where we came from. This was it was a retrospective cohort study in the early 2000s that looked at mortality with timing of antibiotic administration and septic shock. And what was alarming was that half the patients that were admitted to the hospital were getting antibiotics 5 to 6 hours after their presentation, which correlated to a 40% survival. So of the half of the patients that presented, less than half survived, which was alarming. And it further concluded that for every hour there's a delay in giving antibiotics in septic shock, this decreases survival by 7.6%. And so, I should also note, that source control or treating the underlying cause is not just about giving antibiotics. We should also be doing source control, meaning draining empyemas if they're present, getting our surgery colleagues to help us out with abscesses or debridement of neck fascia, et cetera. But I'm a medicine doctor, so we're going to focus on medicines today. And so now we're going to focus on filling the tank, giving IV fluids. And these are the two most important recommendations of the Surviving Sepsis campaign. It recommends giving 30 milliliters per kilogram of IV crystalloids, ideally within, the first 3 hours of resuscitation. And then, what kind of fluid should we be giving? What kind of crystalloid is now we have a better idea that giving balanced crystalloids, such as lactated ringers or plasmolite, is superior to normal saline in our patients that are presenting with sepsis. And I'll talk about why. But I do want to touch on this 30 milliliters per kilogram of IV fluids because I think this is the most criticized recommendation of the Surviving Sepsis campaign. Because what it's suggesting is that we use a one-size-fits-all fluid resuscitation strategy to anyone that's presenting with sepsis, ideally with hypoperfusion. But if we're writing sepsis in our documentation, then we should really be documenting on 30 milliliters per kilogram of resuscitation. But the problem is that what we should instead be doing is taking an individualized approach to volume resuscitation in our patients that are presenting with sepsis. And the bigger criticism is, well, how can you create, it changed from a strong recommendation to a weak recommendation from 2018 to 2021. And how can you create a strong recommendation based on a low quality of evidence? I mean, we use this 30 milliliters per kilogram because it's an arbitrary number that was used in the Emmanuel Rivers trial, which changed what we did. But we should be relooking at this number as more of an individualized approach to resuscitation. All right. I really wanted to harp on that because I feel strong. So and if you were stranded on a desert island and you had septic shock and you could only bring IV fluids or antibiotics, which one would you bring? And the correct answer to this is IV antibiotics, right? Because of what I said before, it's if you take nothing else away, this is what improves mortality the most. And this study was also a retrospective cohort study that included a lot of patients, about 50,000 patients, and it compared mortality and the timing of administration of antibiotics and versus IV fluids. And what it found was similar to the previous study in which the longer we waited to give antibiotics, the more likely our patients were to die. However, the longer time to completion of the 30 milliliters per kilogram of fluid bolus, there was no change in mortality outcomes. And so I think the Surviving Sepsis campaign would like to ignore this study, but it's out there, and a lot of people look at the study to suggest that our amounts of fluid bolus and the way we're doing IV fluids should be relooked at and tailored to a more individualized approach. There are limitations to the study. It is an observational study, but it's powered pretty well and not to be ignored. So I mentioned balanced crystalloids versus normal saline earlier. These are the differences of each of the fluids that we have at our disposal. I didn't really mention this, but what is not recommended to use as initial fluid resuscitation is like albumin or starches or any other fluid other than crystalloids. And for the longest time, we've debated whether or not normal saline, typically surgeons would use LR a lot more than medicine doctors. And there was kind of this debate in the critical care world about who was right. But now we have a better idea, a better understanding that LR is superior. But when you look at the composition of IV fluids, our blood is on the top, the plasma is on the top, normal saline is next, lactated ringer, and then plasmolite. And what you'll notice is that normal saline has a lot of chloride in it. And the reason why, if you talk to any nephrologist, they'll recommend not using this fluid in sepsis is because there's a theoretical risk of developing a worsening hyperchloremic metabolic acidosis when resuscitating patients with normal saline. Lactated ringers has a lot less, and it's theorized that this will potentially mitigate any worsening acidosis in our sickest patients in the hospital. And I do also want to touch on the fact that LR does have 4 milliequivalents of potassium in it. This is not a reason to withhold LR in patients who have hyperkalemia or with renal failure. I mean, it's a negligible amount of potassium that will not clinically raise the serum potassium. I mean, I'm guilty of this too, right? We have a patient presenting with potassium of 7. I'm like, oh, should I really be giving this? But it is superior, and we'll talk about why. So there have been a lot of randomized controlled trials in ICUs in critical care looking at lactated ringers and plasmolite versus normal saline. These are a list of the biggest randomized controlled trials. And for the most part, they were all negative trials, meaning there was no difference between NS and LR. But a lot of what these trials looked at and investigated was patients admitted to the ICU for any cause, not just sepsis. And they were trying to determine which fluid was better overall until the SMART trial came along in 2018. And the reason why this is such a landmark trial and it changed what we did is because of the subgroup analysis that it looked at. And it wasn't a negative trial. It actually had an improvement in mortality. But and so we have to talk about the SMART trial because it's one of my favorite randomized controlled trials of all time. And it was conducted in Nashville, Tennessee. And what it did was it looked at a composite outcome of death at 30 days or mortality and kidney failure. And for patients admitted to the ICU for any cause. And this composite outcome was improved in the balanced crystalloid group. However, that's not the reason why it's recommended in sepsis. This study also had a subgroup analysis that just looked at sepsis patients. And not only was this composite outcome of renal failure or death better, but so was mortality when you were just looking at mortalities individually. So and it had a number needed to treat of 94, meaning for every 94 patients that were admitted to the hospital, giving them LR would save a life and a kidney. So this is why the recommendation of the sepsis campaign has changed. And lastly, we're going to get into maintaining perfusion in our septic shock patients. This this is really kind of mostly patients that are already admitted to the ICU. And here we'll get into vasopressors and and assessing volume responsiveness. But you know what septic shock is it's a form of distributive shock, meaning the systemic vascular resistance is low, you have an increase in cardiac output, and you have a high mixed venous oxygen saturation, you have a low capillary wedge pressure. But you know it's a result of the inflammatory response, meaning that you have leaky capillaries, you have vasoplegia, you have dilated vasculature, which creates a circulatory failure. And giving fluids alone and antibiotics will not correct the significant vasoplegia and leaky capillaries that are existing. And this is where our vasopressors come in to play. And I always think about this, you know, this formula, the mean arterial pressure equals cardiac output times SBR, when I'm administering vasopressors because, you know, we want to target the kind of shock that is existing. So what the guidelines do recommend is starting with norepinephrine, then doing vasopressin next, then adding epinephrine after that. And they acknowledge that if there is myocardial dysfunction or some component of cardiogenic shock present, we can tailor our vasopressors to have dobutamine on board with norepinephrine or perhaps phenylephrine if our patient is is having a lot of arrhythmias on third line epinephrine that we're giving. But I don't like these simplistic models of mechanism of action of vasopressors because it's I don't know, it just doesn't make sense. I like to separate vasopressors into three categories, which is ionopressors, strict vasopressors, and then ionodilators. And I won't get into that anymore because for the sake of time, but you know, I do want to point out that methylene blue is also a tool that we have at our disposal to use in cases of significant vasoplegia from septic shock that is currently being studied. And what's interesting is I included one randomized controlled trial that was done in Mexico that showed a decrease in a decreased time of vasopressors, meaning they came off vasopressors much quicker, but there was no change in mortality when using methylene blue with this. But what methylene blue is, you know, the problem with septic shock is you have impaired nitric oxide metabolism as well, which contributes to the vasoplegia, and methylene blue mitigates this by affecting nitric oxide metabolism. All right, and we know now that we can give our vasopressors peripherally. There's no need to wait to get a central line to start vasopressors. And there are many, many studies out there that have looked at this issue. And what's interesting when you look at all these studies is that, you know, by and large, they were mostly done with norepinephrine, but you know, there have been studies on dopamine and phenylephrine as well. And in many of these studies, they included patients that were getting vasopressors beyond 48 hours at fairly high doses. And even with extravasation events, there was no tissue necrosis that developed. You know, because this is the reason why we weren't starting vasos peripherally before, or we were very scared to, was because of the theoretical risk of causing tissue necrosis from extravasation events. And I can remember in residency trying to, you know, having like 3 central lines set up and, you know, nursing really giving me a lot of pushback for wanting to start norepinephrine on a patient that's in shock peripherally, despite the fact that I'm going to get to your central line later. And now we have a better arsenal at our disposal better evidence to support this. And we should probably be doing, you know, I think peripheral administration of vasopressors is okay for if somebody's just on one pressor, just on norepinephrine, potentially up to 15 to 20 micrograms. But, you know, if we're adding vasopressin, a lot of policies prohibit use of peripheral vasopressin because it has a different mechanism of action. It acts on V1 and V2 receptors in the vasculature in the kidneys, meaning we don't have an antidote for extravasation. Our phentolamine won't work, whereas it can be used with norepinephrine, epinephrine, and others that act on alpha-1. Okay. So bear with me. We're beyond halfway, I think. How am I doing on time? Okay, all right. So what about steroids? And here we're really talking about septic shock, if it wasn't clear before. But there is, let's say we've admitted a patient, they've gotten their fluid resuscitation, they've gotten their antibiotics, they're admitted to the ICU now, they're on 20 micrograms of Levophed and vasopressin. This is probably a good time to start high dose hydrocortisone. And the reason, a lot of, studies have looked at this is because with so much hypoperfusion and poor perfusion to the adrenal glands in particular, there's a risk that patients can develop adrenal insufficiency and often and do. I don't know the exact percentage, but it's not negligible. And these are two big studies that came out in 2018 when I was still in training, which are the adrenal trial and the approaches trial. And they were randomized controlled trials that, in the approaches trial, there was actually an improvement in mortality when you gave hydrocortisone and fludrocortisone to our septic shock patients requiring multiple vasopressors. But the adrenal trial, despite there not being a significant difference in mortality, we knew that the shock was getting better faster. There was a shorter time of mechanical ventilation and fewer blood transfusion requirements. And I can remember at Tulane when I had a patient that was in, he had COVID, but he also had this kind of ventilator pneumonia. He had bacteremia, and we were transfusing him every single day. He was on multiple pressors, and when I came on, he was on hydrocortisone. And I was like, this guy's not bleeding. Why are we having to transfuse every single day? Because the adrenal trial tells me these patients got fewer blood transfusion requirements. And after doing a peripheral smear and looking at it under a microscope, because that's what you do in residency, we saw clumping of his red blood cells and treated his cold agglutinin syndrome with warming all of his IV fluids. And this patient actually improved and he left the ICU with a trach, but he still left the ICU. So why do we pick a MAP of 65? This is kind of another arbitrary number that was chosen early on, but now we're relooking at mean arterial pressure goal. This was a recent study that came out that was a randomized controlled trial in the UK. And they separated patients that were over the age of 65 with septic shock into those targeting a MAP of 60 to 65 versus over 65. And what was interesting is the mortality was actually improved in the permissive hypotension group of septic shock patients. However, this was not statistically significant. So we can't necessarily change any recommendations based on this study alone. But the reason I'm mentioning it is because I suspect a lot more randomized controlled trials will come out looking at this goal to potentially change our mean arterial pressure targets in some patients. So last but not least, we have maintaining fluid balance, meaning assessing fluid responsiveness. This is what I mean when I say this. So the definition of fluid responsiveness is an increase in the stroke volume or cardiac output by 10 to 15% with half a liter of fluid. And you can give half a liter of fluid by raising the legs to simulate an endogenous fluid bolus, or you can give a 500 cc bolus to determine this. The problem is that 40% of patients with septic shock will be fluid responsive in the first place. And of those who are, the IV fluid will probably stick around anywhere between 30 minutes and an hour. So fluids are complicated, and we don't have a great understanding of exactly what to do yet, but we're making strides. And what we should be doing in the ICU when we have our patients admitted for septic shock is ask ourselves, do we want to give more fluid? Is there risk of causing more harm? Meaning, does our patient have severe ARDS with pulmonary edema? Or do they have a history of end-stage heart failure or end-stage renal disease where we could potentially not only third space fluids, but precipitate cardiogenic shock? And once we've decided whether or not our fluids will harm our patients, this is where we ask ourselves, will the patient be fluid responsive? And Emmanuel Rivers, we can't give a sepsis talk without mentioning Emmanuel Rivers. This is what Emmanuel Rivers was attempting to address, is whether or not his patients would be fluid responsive. I mean, what Emmanuel Rivers did was in 2001 was he conducted a randomized controlled trial that changed what we did in our sepsis management. What he did was everyone in his trial got 30 milliliters per kilogram of IV fluids. Everyone got antibiotics at presentation. But in his special group of patients, his early goal-directed therapy group, what he did was he measured central venous pressures every 30 minutes and would give a 500 cc fluid bolus to target a normal CVP. And he also had a special kind of Edwards laboratory central line that measured continuous mixed venous oxygen saturation and would add dobutamine if it was below 70. He also did some other strange things like transfusing to a hemoglobin of 10, which we no longer do. But what was interesting about this study was that there was a 16% reduction in mortality with a number needed to treat of 6.25. But remember, this is in the early 2000s. This is when we had an abysmal strategy at managing sepsis and septic shock. And so what ended up happening was these three trials came out, the Process, Arise, and Promise trials, that looked at Emmanuel Rivers' protocol. And what they did was they compared standard of care, which is basically management that was already being done at the time in acute care hospitals, to Emmanuel Rivers' exact protocol by measuring central venous pressure, mixed venous oxygen saturations, and transfusions to hemoglobin of 10. And what they found was that there was no difference in mortality between what was already being done at the time and doing Emmanuel Rivers' exact protocol, which is kind of why, measuring central venous pressures has really been abandoned for the most part. I mean, we still use it as a tool sometimes. It's just not not necessarily the most reliable indicator of intervascular volume because it can be affected by a lot of other things, especially if our patients have positive pressure in their thorax or have high thoracic pressure from obesity, et cetera. So we're not great as physicians at determining intravascular volume status, but we're better at predicting fluid responsiveness. And what the guidelines suggest is that we should be using what's called dynamic measures of assessing volume responsiveness rather than static parameters alone. This is the correct answer on the critical board exam, is using our ultrasound machine to look at, distensibility of the IVC or VTI, which basically measures the cardiac output before and after doing a straight leg raise test or giving IV fluids. So for the sake of time, I'm not going to get into pulse pressure variation. I love pulse pressure variation because I think it's fascinating, but it's just the problem with measure. And basically what this is. All right, I'll touch on it a little bit. What this is essentially is we put in an A line and we measure the variation of the arterial waveform. And the problem with assessing volume responsiveness in this way is that patients have to be intubated, they have to be in sinus rhythm, and ideally they should be paralyzed, although that is kind of debated in the literature. And they also have to be receiving fairly high tidal volumes for us to use this, which we're really trying to avoid, especially in our patients with any amount of lung injury. And it kind of tells us where we are on the Frank-Starling curve, which is why I like it. But what's probably more useful is doing a leg raise test. It is not recommended to do a passive leg raise and just look at the blood pressure and heart rate because these are static measures of volume responsiveness. What we should be doing is utilizing our ultrasound machine and measuring VTI to determine if our cardiac output increases by 10% with raising the legs. And it's something I've tried to get better at in our ICU here. The problem is that we're not necessarily trained on doing very well or very often in residency. Perhaps that's different in a critical care fellowship. I'm sure it will be. But if you step back and you kind of ask yourself, well, do we really need to do VTI assessments and take all this time on 14 patients admitted to our ICU to assess volume responsiveness? Because what we said before was that even if our patient that's in septic shock is fluid responsive, that fluid will likely be third spaced in about 30 minutes to an hour. So, I don't think we have a great answer. So oftentimes what we'll do is we'll just give if there's no major risk to giving fluids, we'll kind of give a conservative amount of fluid and see if this helped our patient's hemodynamics and lactate. But that's, what we should be doing is using our ultrasound machine a lot more. All right, and last but not least, this is kind of the moment we've probably all been waiting for, which is examining the utility of CMS performance measures. And uh, because I know it's a big thing our hospital has been engaged in over the past several years. But I found this cross-sectional study that I thought was really interesting. And what this study looked at was, who was reporting on these SCP-1 measures most, and then of those who reported, who was doing the best, who was doing the bundles the most. And what they found was that small for-profit non-teaching hospitals were reporting on these measures less, but they were doing much better at it when they do. So I know we're a nonprofit hospital, I think we are, but being a small hospital that is a non-teaching hospital, I think we're poised to do really well in these SCP-1 performance measures. It's just, in my opinion, I don't necessarily think they should exist in the first place, and I'll get to why that is in a second. But so I mentioned that smaller for-profit non-teaching hospitals did better in their SCP-1 performance. So what does this mean? Should we be transferring our patients with severe septic shock to these small for-profit non-teaching hospitals? No, I mean, that's ridiculous. I mean, we know that these larger academic places have much better critical care management with more resources such as ECMO or Impella devices if our patients need these. But there have been a lot of studies that have looked at whether or not the CMS performance measures improve mortality. And I think it's a bit premature to have a government-wide implemented program that dictate what providers do in hospitals, in particular, because a lot of things still need to change with the sepsis guidelines and get better. Even our screening tool that we use needs to change, which they're looking at. Right now they're looking at some measuring cytokines to see if we have a better way of diagnosing sepsis from bacterial infection. But these are two trials that, the reason I'm bringing this up is because of the trials that show an improvement in mortality. When you risk adjust those trials to separate out septic shock patients from just normal sepsis patients, there's not a significant difference. And so right now there's very little evidence that actually suggests these measures actually improve mortality outcomes. And I want to leave us, and so as providers, we're kind of left between, well, should we be going on the CMS performance measures that are still looking at old 3 and 6 hour bundles from 2016, or should we be really listening to the Surviving Sepsis campaign, in which everything should be happening in the first hour? Or should I be doing what I want to do, which is take an individualized approach to volume resuscitation in the septic shock patient and treat them accordingly? And so it's a confusing time, I think, to be a provider when managing septic shock, but things will change and get better. And this is I read this meta-analysis opinion on this, and I want to leave us with their quote, which is, any future basing of hospital accreditation on reimbursement on the use of SCP-1 interventions for all septic patients will transform unproven practices into universal care and potentially harm patients in whom they are not indicated. Moreover, requiring the reporting of these interventions as a CMS performance measure will consume personnel and financial resources that might be better directed to other more effective therapies. And then we'll see, I made this presentation at a time when this guy was, selected by Donald Trump to be the next head of CMS. So we'll see what happens with that. But what should we actually be doing? And I put the Kennedy bundles up here, which we shouldn't necessarily be looking at. But instead, what we should be doing is, yes, getting a lactate or measuring a capillary refill time and repeating this if they're abnormal. We should be trying to get blood cultures before antibiotics, and we should be administering targeted antibiotics based on prior sensitivities or treating the presenting illness. I mean, if somebody's in septic shock, we can always de-escalate antibiotics. So it's best to start with more broad spectrum antibiotics if we're not sure what's causing their hemodynamic compromise. And then I don't know, I don't necessarily have the best answer of what we should do instead of 30 milliliters per kilogram for everyone. But I can tell you that what is being suggested right now in the guidelines is potentially dangerous and harmful to a subset of patients that are presenting with another form of shock, that being cardiogenic shock. And I think Omar and I took care of a great example, a great patient the other day that speaks to this. There was a patient that was fairly young that was presenting to our emergency room with fever, tachycardia. He had sepsis, and he was given 30 milliliters per kilogram of normal saline, which we know, LR would be superior. But and he was also given antibiotics, and we admitted him to the ICU, or actually he was admitted to the floor because he was hemodynamically stable at the time. After our nurse practitioner went up and saw him and said she was worried, I looked at the guy, and he was, it was a very concerning picture. He had significant mottling over his entire lower extremities and lower abdomen, despite having a normal blood pressure and normal heart rate at the time. And his lactate had increased from 3 to 6 after getting 3 liters of IV fluid. And what the Surviving Sepsis campaign would suggest is that if our lactates increase, we can use this to guide farther volume resuscitation, i.e. giving more fluid. But that would have killed this patient because after we got the transthoracic echocardiogram, this revealed that he had an EF of less than 10%. He was in cardiogenic shock and ended up started dobutamine, norepinephrine, transferring him to St. Mary's, and then he got an Impella. He was transferred for ECMO, and he actually had a positive outcome. I saw he went to the primary care clinic and was weak and tired, but alive. So, all right. And then lastly, we shouldn't use IV vitamin C. Okay. Thank you all very much.
Excellent job. Excellent job, Dr. Kennedy. Thank you so much. If you have a question, you're attending virtually, please put that in the chat. We'll read that off. If you have a question and you're in person, Dr. Kennedy, if you can please repeat that question, we'd appreciate it. Thank you.
Looking for the question. Where do I find the questions? Okay. All right.
Okay, from Dr. Arja, well done. Awesome. Thank you, Dr. Arja. While we're waiting to see if anybody has a question, this coming Wednesday, we have a new program starting. We're going to start, it's called Pharmacy Focus. It's with our very own Tyler Knight from Pharmacy. This month, this will be the third Wednesday of each month from 12:15 to 12:45. It'll be virtual only. And this time it'll be focusing on migraine medications. This is in direct reply to what your evaluations have been asking for. So we are trying to make that happen. Any questions in the room?
You come across Zygris at all?
No.
Zygris. There's always these new things in sepsis. Everyone's trying things in sepsis. There's medication, I think it got discontinued in 2011 or something.
Yeah.
Zygris was supposed to be Eli Lilly's answer to sepsis, and it's supposed to limit the inflammatory cascade, stop the cytokines. Didn't work.
Was this activated protein C or this is something else?
Something like that. No, it's got a weird name of pharmaceutical.
Because I know that in the original models, there was a recommendation to use activated protein C, but with almost no evidence to support its use, or of the evidence that was there, it was really biased. And it was a good example of how this initial campaign was funded by these corporations that were pushing their drug.
Yeah.
And so that is no longer recommended. Yeah.
And then the vitamin C and thiamine together was a huge thing a couple of years ago.
Mm-hmm.
Big, huge study. A lot of centers got involved in that. It was started by the guy who then became a big COVID denier.
Yeah. And I saw that, there had been a number of years where we had been looking at vitamin C and actually using it. I can remember in med school, us giving IV vitamin C in ICU, which now we don't do anymore. And the Lovett trial, I think, is the biggest randomized control trial that showed increased mortality with use of IV vitamin C in septic shock. So
And then there is a newer pressor that actually does show mortality improvement if you add it as a second line.
angiotensin too.
Angiotensin II, Giapreza, yeah. So
Yeah.
I think we're going to see that come up in the guidelines over the next iteration or whatever.
Yeah.
Um,
exciting time to be alive and
Yeah.
start fellowship.
I mean, the pendulum swings in medicine, you know, when I was a resident, it was like fluids, get the CVP, get fluids, keep giving fluids. And then it swung when I was a fellow, it was like, nope, stop the fluids early, start giving pressors early.
Yeah,
Peripheral pressors, you know, and then it's kind of like, where's the medium?
exactly. And there have been, like, they have looked into like a fluid restrictive strategy of resuscitation. There's a big study that came out, but the problem, which didn't show any major difference. But the problem with that study was between the difference of the amount of fluid between those two groups was like only a liter. It wasn't necessarily that significant. So it'd be interesting.
Okay, we've got a question online from Emily Godfrey. When does the clock start? The moment the patient checks in at the ED or at the time they are triaged?
I think that's a better question for the administration because, ultimately, the clock starts as soon as they hit the door of the emergency room, in my opinion. Because the fact of the matter is, the sooner our patients will get IV antibiotics, the more likely they are to survive. So it's when they walk into the door. Um, because I think it's important to take our CMS performance measures with a grain of salt. I think they can be useful in tracking our sepsis measures in that we can see who didn't get antibiotics within the first hour with septic shock, because we can go back and revisit why that was the case, why that was a fallout. But so I think that's the way we can use it, and we should, because our hospital, we should be reporting on SP1 measures, because our hospital could use the added resources that we get from that. But what's more important than all of these things is doing what is right for our patient in front of us, and that means doing things as soon as they get here. I think triaging patients in the emergency room, it's easier to triage the patient that has chest pain sooner than it is the patient that has soft blood pressures with a fever. But the mortality associated with septic shock is actually much higher than myocardial infarction. And so I think it's something that we should be prioritizing patients that have signs of poor perfusion and hemodynamic instability with sepsis as soon as possible, and not waiting to call the hospitalist to ask what antibiotics to give. They should be giving them as soon as possible. I mean, use vancomycin. I mean, I'm okay with that. There was a big ACORN trial that came out that suggested that kidney failure with the combination of vancomycin may not actually be as much of a concern as initially thought. I think now I typically avoid vancomycin more because cefepime can worsen encephalopathy and delirium and cause neurologic issues. So
UC Health in their sepsis protocol in their emergency department, they've got it, Epic is set up so that if there is, if they meet criteria for sepsis, there is an automatic order for levofloxacin before a provider ever even sees that patient. So that medication is coming down, and it actually takes a stop from the provider to stop that antibiotic from being given.
Yeah.
And their sepsis numbers are spectacular.
Right. And that is the way to beat the system, to make our outcomes better, is to give antibiotics to more people. I mean,
are their real outcomes better or just their CMS numbers are
the
better?
CMS,
Their real outcomes are better.
but I think it's important to note that CMS, that's what hospitals care about, that especially if they're for profit. And those are going to be better if you give antibiotics to more people.
Yeah.
And the problem with sepsis now is that SIRS criteria, like we mentioned before, high sensitivity, low specificity. So, anybody with a panic attack is potentially going to get antibiotics, which could lead to development of hospital-acquired infections like C. diff down the road, which will potentially worsen mortality and increase our antibiotic resistance that's already present. But we need a better tool for screening sepsis than SIRS criteria in order to mitigate this issue much more. I think the answer right now is, give antibiotics to everyone. Why not? If you have any question whatsoever that bacterial infection is contributing to their sepsis, then give something within the first hour. But it's not ideal. You need a better tool. Yeah. I don't mean to, yeah, I don't, am I coming across professionally or?
Yes.
Okay.
But I think you're right, like, until we have that better tool, what do? You give antibiotics often and early, and then de-escalate it.
Yeah.
You know, that's what we do now.
And I mean, they even, I can remember, and I don't remember all the names of these trials because there's so many I've like reviewed over the last, number of months, but they did even do a trial where they gave ceftriaxone like in the ambulance, for patients, everyone that met like first criteria or some screening tool, and they compared the outcomes of those patients. And what I remember was there was no like significant difference in mortality, but why choose ceftriaxone? Like I just, there's a lot of information out there that I don't necessarily think we can use. But I think at the end of the day, our issue is we still have a very primitive way of screening for sepsis and managing IV fluids. And that is ultimately, those two things ultimately are what need to change. And the problem with having CMS measures in place now, in my mind, is, it's going to be harder to conduct studies in the United States when you have hospitals that don't want to go against doing CMS measures, potentially. And so, that, in my mind, now is not the right time to track sepsis numbers nationally.
So going back to UC Health,
Yeah.
Jeff Lachine is their chief quality officer for their whole institution. And he basically, it was at a talk he gave, he's a hospitalist. And he basically said, for us, we say, screw the CMS measures. We are going to do what's right for patients.
Yeah.
And treating sepsis means early antibiotics. And if we miss out on getting the cultures done, I don't care.
Yeah.
We're not about, making the government happy. We're about saving patients. And
Yeah.
and their data, proves that their sepsis survival is higher than national average.
Absolutely. And I mean, I think to that point is you're going to treat somebody, like, say there's a 90-year-old that comes in, has had diarrhea for days, who has an infected stone. That person might need more fluids than somebody that, has, I don't know, like an empyema, like let's say ARDS from bacterial pneumonia. Like, it's ridiculous that we should consider giving the same amount of fluid to both of those patients when not taking the clinical context into consideration. And that's when I get kind of the most, worked up is not necessarily looking towards the guidelines, but looking at my patient and being like, this patient needed more fluid. Why are they on 2 pressors and they're not getting more fluids? When I think they could benefit from it, that's when I get passionate about my job, yeah. Anyway.
All right, I'm not seeing any more questions or conversation. This was great. Thank you so much, Dr. Kennedy. Excellent job. Lots of great information for everybody. Happy Valentine's Day and drive safe out there. Have a wonderful Friday.
All right. Thank you.